Hi, everyone. Firstly, my name is Motaz. I'm one of the SHRO rotating trainee. Um, I'm going to present today the topic of pyrexia of unknown origin. So we're going to start by the definition. So pyrexia of unknown origin is defined as a persistent temperature of more than 38.3 degrees for more than 3 weeks, evades the diagnosis, and including 1 week of investigation inside the hospital. This is the old definition. Okay. So what changed? It's changing that the 1 week of hospitalization is no longer essential to fit the diagnosis of pyrexia of unknown origin, especially that with evolving of medical care and the faster and more accurate of the investigation modules we have it today. Okay, we have here like a case discussion. A 28-year-old lady born in Canada. She present with a fever of 40 grade for 2.5 weeks. She also complained of rash in her lower legs, red tender nodules. She works as a bank accountant, no smoker and no drinker. She's using oral contraceptive pills. So this is the initial history that we got it from the case. The question here is the diagnosis of PUO of pyrexia of unknown origin fits her case here? So we'll find the answer later, but we'll go for the categories of pyrexia of unknown origin. The categories of pyrexia of unknown origin has been suggested to help in organizing the approach of the patient evaluation and to find the etiology of the pyrexia of unknown origin. So it's categorized to infectious, inflammatory, neoplastic, and miscellaneous. So this is depending on the etiology of the pyrexia. And this will help that to find out how we can approach the patient, how can approach the investigation. The infective etiology. The most common cause of pyrexia of unknown origin in immunocompetent is infective endocarditis, discitis, osteomyelitis, occult abscess, infected implanted devices. In patients with expected endocarditis and those who have negative blood cultures, and we are thinking that they may have infective endocarditis, an extended culture for Hasek organism, which is a Haemophilus actinomyces, Echinella and Kingella, and serology test for Coxiella, Bartonella, and Procella should be done. Immunosuppressant patients. The immunosuppression increase the risk of the infection, which may present as a pyrexia of unknown origin, especially the causes could be like bacterial, such as pulmonary and extrapulmonary TB, non-typhoidal salmonellosis, and syphilis, viral such as arbovirus, parvovirus, Coxsackie virus, and cytomegalovirus Epstein virus, fungal such as aspergillosis, candidiasis, and cryptococcosis, parasites such as visceral leishmaniasis. So the immunosuppressant, they are on the risk of getting the infections, and this is the most common infection that can lead to pyrexia of unknown origin in the immunosuppressant patient. The other category we have it is inflammatory etiology, and we have a numerous inflammatory disorder that can lead to fever, such as systemic rheumatic disease. Example for it is a polymyositis, vasculitic process such as temporal arthritis, anti-inflammatory disorder. Example for it is still disease, and granulomatous process such as sarcoidosis. There are often multi-system conditions requiring multiple confirmatory investigations, especially that for the inflammatory etiology. And it needs multidisciplinary approach to management. Sorry. Other thing that is a neoplastic etiology. Fever in neoplastic could be due to the malignancy itself or in associated as a paraneoplastic process, as well as opportunistic infection. There is a criteria that for diagnose a malignancy related to varicose of unknown origin, which is they found that the fever of the malignancy is highly selective that to respond to naproxen than the other anti-inflammatories. Okay, back to the case again. And the question was, is her case that is fitted to be diagnosed as pyrexia of unknown origin? So the answer is no, and that's why, because she's having a fever for less than 3 weeks, and the patient was not investigated before. So we can't say that she had a pyrexia of unknown origin. Diagnostic approach. The cornerstone, I think that in the diagnose or to diagnose the pyrexia of unknown origin is the history. A detailed and a comprehensive history is essential in order to get a real underlying etiology. And sometimes we need to go back in the history for months and years. Essential part to focus in the history is that the pattern of the fever, is it intermittent, is it continuous fever, and the past and medical and surgical history, past medical and surgical history, drugs and vaccinations, a detailed traveler history, environmental work, contacts with animals, illness in contacts, family history of similar illness, and the red flags as well, which is a weight loss, drenching night sweat, inability to perform daily living activities. Then we'll go after that to the physical examination. Again, a comprehensive and detailed examination from top to toe. There is some point that we need to bear in our minds is that we will not forget that to examine the spine and joints, skin and mucous membrane, femoral arteries, and breast in women, prostate in men, and any implants, which could be potential sites for infection. Okay. Back to the case, her fever persists, and a detailed history and physical examination non-contributory, except for intermittent skin lesion on her lower legs. Given what we know, what investigation would we order? So this leads us that to the next thing, it's the investigations. To investigate a patient that we are thinking that they have a pyrexia of unknown origin, the investigation should be conducted in like a baseline investigation and specific investigations. And he should have like a 2 baseline test followed by then a specific test. The baseline test is full blood count, clotting screen, CRP and ASR, liver function and urea and electrolytes, at least 2 blood culture tests, HIV, chest X-ray, urine dipstick, and microscope and sensitivity as well. Then after that, we can proceed for the potential investigation, potential specific investigation, sorry, which is include the microbiological test, MX and biopsies. For like infection, and this is again depend on the category of the etiology. If we are thinking that it's like infection, so the most common specific tests like echocardiogram, lumbar puncture, lymph node biopsy, sputum culture and microscopy, wound swab, malaria test. This is an example. It's not like and the whole investigation that we need to do it. In case of inflammatory autoimmune antibodies screening, such as NA, ANCA, rheumatoid factor, complement level, immunoglobulins, anticyclic citrulline peptide, antiphospholipid, anti-double strand DNA, and serum angiotensin converting enzyme. In case of we are thinking that the underlying cause, it could be like a neoplastic, a CT for chest, abdomen, and pelvis, serum calcium, serum electrophoresis, Bence-Jones protein, biopsy from the tissue, lymph nodes, or bone marrow. The PET scan. The availability of the PET scan and make it more to be used as a first or as one of the specific investigations. Because it's identified the metabolic active foci of infection, inflammations, or cancer as possible cause of the pyrexia of unknown origin. Yeah, this is the most important point. The blanket investigation are not recommended, because if you are going to request the investigation as randomly, and you are seeking that you are going to cover the whole possibilities, some tests will come positive, and the patient or the person, he doesn't have like a symptoms or the syndromes that fit with the positive test, and this can lead to misleading for the underlying cause, and even can cause the potential cause for patient harm. The management. Management of pyrexia of unknown origin is supportive until we get to identify the underlying cause. Therapeutic antibiotic or steroids as a trial is not recommended, because this can mask the symptoms and the signs of the underlying cause. There is some situation that we can use that the antibiotic and steroid as empirical, and this is like on 3 situations, which is suspected miliary or CNS tuberculosis, or there is a suspicion of infective endocarditis or temporal arthritis in the inflammatory category. So back again to the case, we did the initial investigation, which is a full blood count with differential UNEs, calcium, phosphate, magnesium, all within normal. Our liver enzymes show that there's mild increasing in AST and ALT, then it's come to normalized. Our ALP, bilirubin, albumin were normal. ASR is 39. Blood cultures doesn't show any growth of any organism. Viral hepatitis, HIV, cytomegalovirus, and Epstein-Barr virus were negative. Then for ANA, ANCA, rheumatoid factor also are negative. Echocardiographs, CT, thorax, abdomen, and pelvis are remarkable. A skin biopsy from the site of the lesion was unremarkable. No subcutaneous material obtained. So despite multiple outpatient visits and short in hospital admission, there was no clear diagnosis. A decision of PET scan was taken. However, the patient had a short antibiotic course from her GP and her symptom resolved. She decided not to go further for test and stop her follow-up. This leads us to main point here. In some cases, spontaneous resolution may occur, and in other, a watchful waiting period is necessary. The overall mortality in pyrexia of unknown origin is low, particularly in those who are well enough to be investigated as outpatient. I think that the main point that can be frustrating for the patient and for the doctors that is you are being investigating for something that you are not know what is it, and the patient is like having the symptoms and he couldn't find any beneficial from this investigation. So I think that the first thing that to address the expectation of the patient to be more open and more frank with him that sometimes we are doing this investigation and we cannot get any like a definitive cause that for this pyrexia. So he will be know what he's expecting that to have. When investigating a patient with pyrexia of unknown origin, you should consider possible etiology in the 4 broad categories. This is what's the important points that we need to remember. So the investigation should not be like a random investigation. We should think about the underlying etiology and run the investigation dependent on what we are thinking about. Blanket investigation are not recommended. Trial of therapeutic antibiotics and steroid are not recommended as well. I think this is the most important things. Thank you. If there is any like question, I'm happy to answer.
Thanks a lot, Motaz. Does anyone have any doubts? Do you want to ask anything to Motaz? Pin drop silence. So I believe nobody has any doubt right now. Anyway, Motaz, that was a really good presentation. Okay.
Thank you. I'm going to stop by sharing my screen.